and welcome to another episode of Keeping London Healthy. My name is Dr. Mario Elia. We'll be talking about osteoporosis today with endocrinologist Dr. Emily Brennan at LMC London, and she'll be answering all our questions about osteoporosis. Just a quick reminder to patients before we get into the meat of our chat today, a reminder about COVID vaccinations and flu vaccinations. So again, everybody should be getting their flu shot. We're seeing a lot of flu already coming into the community, and obviously a lot of patients ending up in hospital. And for COVID vaccinations, if you're a high-risk patient, especially 65 plus, and it's been over 6 months since your last COVID vaccination, please consider getting it. So in COVID vaccinations, flu vaccinations, we need to keep down our risk of viruses in the community. We'll take a quick break, and when we come back, we'll be talking with Dr. Brennan. All right, welcome back. Again, I'm pleased to be joined today by Dr. Emily Brennan. Dr. Brennan is an endocrinologist here in London, working at LMC London, and she'll be talking to us today about osteoporosis. Thanks for joining us, Dr. Brennan.
Thank you so much for having me.
So we'll start with kind of what is osteoporosis, because I know that term, some patients may know what it means, some patients may be confusing with other conditions of the bone. So what is osteoporosis in your own words?
So osteoporosis is a condition where people have low bone density. And by that, we mean that the bones themselves are not as thick. And so they have higher risk of fracture. And you're right, it is a confusing term. A lot of people think of the term osteoarthritis. And so we're thinking about pain in their joints. But osteoporosis is a silent disease because it's just the bones themselves are getting a bit thinner and makes us higher risk for fracture. And when that happens, that's when they have pain. And unfortunately, we've missed an opportunity to prevent that.
And it's good you mentioned the osteoarthritis, because often when we diagnose them with osteoporosis, the first thing they'll say is, "Oh, that's why I've been having all this pain." I'll say, "Well, it has nothing to do with pain in your knees and pain in your shoulders, and that'll be from osteoarthritis." So
that's exactly right.
Important distinction to make. So how do we screen for osteoporosis? Like, how do we find whether a patient has it or not?
So there's actually two main things. So your doctor may ask you a lot of questions because we look at different risk factors. And then the most common test we do is a special x-ray called a bone density. And it's done, we look at mainly the hip and the spine because those are the most common sites of severe fracture. And so they're very good places to actually assess what the density is.
Or who should be asking their doctors about potentially getting a bone density? Who are high risk people who we want to be targeting?
Yeah, so that's a great question. And really, everybody over 65 should be screened, both men and women. And men are often forgotten, or just we don't really think of it as a disease for men, but we really do need to think about that. So, anyone over 65, if you have had a fracture and you are over 40, then that also should be looked at. And then there are some people with higher risk conditions like rheumatoid arthritis with chronic prednisone or steroid use, people who may have absorption issues like bowel diseases, bariatric surgery patients as well. So there are a number of unique people who are under 50 and even between that 50 to 65 group, but everybody over 65.
Question that'll often come up after patients have a fracture is whether or not they should be having a bone density after that fracture. Can you tell us a little bit about what kind of fracture would warrant a bone density?
That's a great question, actually. So we always are concerned about fragility fractures. And that is when people might have had a fall from a standing height, like a slip and fall on ice. A person with normal bone health shouldn't fracture in that situation. So it really is a fall from a standing height, or if it is a height less than 2 stairs. So if you fall down all your stairs, that would be a normal time that you would fracture, which would be unfortunate. But if it's from 2 stairs or less, you should not be fracturing with that fall.
And I know even in my own practice, patients with osteoporosis who are under 65, the number of them with a history of, I'll call it excessive alcohol use, is fairly high. So it's a group that we as physicians sometimes forget, but one that we definitely don't want to ignore. Any risk to a bone density? I know it's kind of a little bit mysterious in the patient's eye, and they're worried about risk of radiation. And is there any true risk to a bone density?
There really isn't. And I think there is always that distinction. A lot of people think bone scan, and a bone scan is different. This is just a bone density, and it is an X-ray. And it really would be equivalent to taking a flight to Vancouver. So, or just having an X-ray of your chest. That there isn't. You're right. It's not no risk, but it is so low that we would, do that as part of our regular travel and not even think about it.
Absolutely. And again, the distinction between bone scan and bone density is an important one. Two totally different things. Bone scan, you'll often hear if someone has cancer and or suspected of having malignancy, they'll get a bone scan, which is a head to toe nuclear scan, which does there's a bit high risk of that, but a bone, like you said, bone density, X-rays, a very low risk. We'll take a quick break and we'll be right back with more from Dr. Brennan. And we're back with Dr. Brennan. Dr. Brennan's an endocrinologist here in London at LMC London. So we're talking a bit about bone densities, and the patient gets the bone density, doctor gets the information back, and how do they use that information with the patient? Are there numbers that are used or risk calculators? What kind of things does the patient get information about from the doctor?
So when we get that information back, we use it in conjunction with asking a lot of questions. And there's a scoring system we use called the FRAX, which was developed by the World Health Organization about 2008. And it really puts together what the patient's fracture risk is along with the bone density number. So we're not treating the number, but we're really treating that whole patient. So your doctor is most likely going to ask you about a number of questions, including what your weight is, your height, if you've had a previous fracture, if your parent has had a prior hip fracture, about alcohol use, smoking, and then about history of rheumatoid arthritis and prednisone. So we're going to take all that information, and if you have a lot of those things, then obviously your risk of fracture will be higher. So it's depending on the bone density, you may require treatment, basically, when we take that all together. So if your risk of fracture is greater than 20% over the next 10 years, so not every year, but over 10 years, then we would be recommending a medication along with lifestyle changes. If someone's risk is more like 10% or less, then we would just recommend exercise, calcium, vitamin D, and just lifestyle measures. In that 10 to 20% is a gray area. So you and your doctor are going to be working together to decide whether you would benefit from a medication treatment or whether it makes sense just to monitor, but do those things like weight-bearing exercises, calcium supplements, and vitamin D.
And patients may be familiar with this kind of risk-based conversations around cholesterol. I know a lot of doctors are having these same conversations with patients when they get their cholesterol numbers back, and it's not a yes you should be or no you shouldn't be. It's well, here's your risk, here's a conversation. So shouldn't be something that's too foreign to patients. We'll talk about treatment in a second, but for those patients who have a bone density done, doctor says that they don't need medication at present, just going to monitor it. Can you tell us a little bit about when that patient should be asking for their next bone density or when they should be expecting another bone density to be done?
Yes. So in a low risk population, what we're monitoring, usually once every 5 years is sufficient to kind of monitor that. If you have are in that moderate risk category, particularly if you're edging up to that higher risk, then you might be doing it every 2 or 3 years. If you fracture, then that's the time that you're going to want to obviously get that treated, but you want to then speak to your doctor because that often is a time that we would want to then initiate treatment.
And for future bone densities, I know patients will often be told by their doctor that they have to go to the same facility each time for a bone density. Can you tell us a little bit about kind of the rationale behind that?
So there are different machines and they're calibrated differently. And so it actually is quite important that you are going to the same machine. Sometimes this is not all within our control, obviously, and technology gets updated, they get new machines. So it actually does become a new baseline. But I have seen in the past that somebody gets their bone density on a different machine and it's dramatically either higher or lower. And so we really do need to keep that in mind, and that if you can, please go to the same location.
So for those patients who they've had their bone density, they speak to their physician, decision is made that yes, they need treatment for it. What options are available first line for patients for treatment?
So we're actually quite fortunate that we have a lot of agents that we have, and they are quite effective. The most common agent that you'll see is bisphosphonates, and these come as a pill, and they're usually taken either once a week or once a month. And this kind of medication actually stops our bones from breaking down. It's actually quite interesting. Every 5 years, our whole skeleton is basically rebuilding itself, just like maintenance on your house. But again, we don't see that or know about that. So what we do, the medication will halt the breakdown. So we're actually going to see more bone building. And this reduces our fracture risk by about 50%. So very effective. But what's interestingly, in the bone density, we really want to halt that decline. If it's stable, we're happy. There may not actually be increase on the bone density, but what we're preventing is that loss.
And I know some options are weekly versus monthly for bisphosphonates. Any preference or any reason why to choose one or the other?
So it really depends on the patient. We're seeing a lot more weekly medications, some of the diabetes and rheumatoid arthritis. So those people actually quite like the weekly agents because that they have already a habit and they tend to find they do it every Sunday. But I do find there are some people. I had one just recently, and you know what? It just wasn't working. And so the once a month was actually better for this person just because it was a little bit more forgiving. If she forgot it on the first of the month, she took it the second. She didn't miss the whole month. Whereas some of these other with the weekly, if they miss one, oh, I'll skip it till next week. And then they're ending up missing a lot. And that's going to actually negatively impact their bone health.
And any difference in effectiveness or tolerability between the two, weekly versus monthly?
So there is one of the weekly agents is called a delayed release, and it can be taken with food. And so some people really struggle with the GI upset with taking the medications, and that's always the go-to for those individuals. So they don't have the monthly option. It's a funny medication because unfortunately it can have a lot of heartburn and reflux. And so when you take it, you actually need to be upright for 30 minutes after. And most of the medications are without food, but one of them is with food. So there are some nuances and patients need to be aware.
For patients who get heartburn the first time they take their bisphosphonate, or they get it a few times, what's your general approach with that? Are you recommending that they stop it for a bit and then restart it and try it? And how successful do you find that is? Or do you find you're jumping to a second line agent pretty quickly?
I do like to give patients a chance to try it out a little bit longer. Sometimes they, with increasing their calcium intake as well, they may be using Tums, which can also help with heartburn. So there may be other treatment options, or maybe we're just unmasking untreated heartburn. So they could benefit from a trial of a different medication as well. But I do like to persist with it because it is a very effective form and it's quite well tolerated. And there can be issues with switching to other agents as well. So it's heartburn alone isn't enough just to make me jump until that patient really tells me, hey, I'd like to try something else.
Patients may have heard a number of years ago about bisphosphonates, about some controversy around some atypical fractures that some patients were getting. And I know this hit the news, and a lot of patients kind of stopped their medications abruptly. And now that it's been a number of years, what can you tell patients about this controversy with atypical fractures, and do they need to be concerned?
So unfortunately, it is a real adverse effect or a real side effect that is possible. It's extremely rare, which is fortunate. And basically what we found is that bisphosphonates, while they're helping with that, stop some of the bone breakdown, people who are on these medications for a very long time actually get some kind of like hardening of the bone. And they call these chopsticks fractures because it's almost breaking like chalk. So it's very rare, and it's from hardening from long-term use. So what we've actually seen is these medications stay in our bones and are working for us even after we stop them. So we're using a lot more drug holidays. So often low risk patients are on these now for 3 to 5 years, maybe up to 10 years. Then we take a break and we watch them to see, are they having bone loss? Are they fracturing? So this is really making a difference to preventing these atypical femoral fractures. And then the other thing that we've chatted about, there's always risk and benefit. So every medication does have some risk. Yes, it is there, but their personal risk of a hip fracture or a vertebral fracture would be far greater than having an atypical femoral fracture. It's in the range of about 1 per 100,000 patients, so quite low.
And again, and it's important to put that in perspective for patients that yes, this is a risk, but the risk of the fractures that we're looking to prevent with bisphosphonates is far, far higher. I know in my practice, I haven't seen any atypical fractures, and not an endocrinologist, but still a lot of patients on bisphosphonates. And I'm sure in your practice, it's,
we see a lot, and it is not something that comes up very often. And they tend to have been people who have been on these medications for 20, 30 years. So that's not something we're doing today. That's the honest answer.
So a patient who takes a drug holiday, how long can that bisphosphonate stay in the system for? And if we see bone loss, years from now, how long after do we even consider maybe putting them back on the medication that they were on before?
So often that holiday can be 5, 7, 10 years, which is pretty exciting. So what we do is you want to do a bone density the first year after the break, just to make sure that nothing surprised you and that there wasn't a big drop. If that's good, then you'll probably do a bone density every 3 years or so. And around that 7-year mark, you might even go annually because you're expecting some decline to kind of start to kick in. Or if the patient fractured, then that would be a time to then resume the medication.
So again, an important group that if you're part of a group, you've been on osteoporosis medication in the past, and it was stopped because your bones were improving, or make sure that you touch base with your physician periodically just to make sure we're not falling through the cracks. Because again, if you've seen some bone loss, it may be something we want to get back on. So back to bisphosphonates. I know dentists will, dental issues around bisphosphonates. So patients will have often heard of a condition called osteonecrosis. So we're talking about really, really, really rare side effects. What do patients need to know about this rare risk of bisphosphonates?
So again, it is a real condition. It is a risk. Again, extremely rare. We tend to see that in patients who unfortunately have cancer and they have bone metastasis or multiple myeloma. So again, a bone-related cancer. They are on much higher doses of these medications, often getting every 6 weeks IV forms. So a high dose, high frequency, and that tends to be the group that has the highest risk of this osteonecrosis of the jaw. We do know if you are planning on starting this medication and you're going to have a lot of dental work done, by that I mean implants, yes, do it before that medication. Seeing your dentist regularly and good dental hygiene is protective. Smoking is also a big risk factor. So, encouraging stopping and quitting smoking, and just knowing that it is it's very rare in patients who are on the medication. I had looked at the numbers, and they do it in patient years. So if from 10,000 patients were on these medications for 10 years, one would have ONJ. So again, the personal risk of a hip fracture would be far greater than the risk of osteonecrosis.
Perfect. So in summary to patients, if your doctor has recommended a bisphosphonate, yes, these things that we've discussed, the atypical fractures and the osteonecrosis, yes, they are real risks, but exceedingly rare, and the risk of fracturing a vertebrae in your spine or the risk of fracturing a hip much, much, much more common than these rare side effects we're talking about. Just put them in perspective. So we've talked about bisphosphonates. So if a patient either doesn't tolerate a bisphosphonate, or let's say their bone density continues to get worse on a bisphosphonate, or they fracture while on a bisphosphonate, what are some second-line treatments that are available for these patients?
So that it unfortunately is a treatment failure, or they just failure to tolerate it. And so then we do have a few great options. So one is actually an IV form of a bisphosphonate, and that is actually just once a year. And usually that one can be given for 3 years, and then a holiday actually can be done as well. It is more tolerable from a GI perspective, so it is a great option. Then we have another agent called denosumab, which works in a completely different way, but it also is helping with that bone building process. So that is a medication that is actually given once every 6 months, and it's given like a flu shot, so just an injection in the arm. So it's very tolerable, no upset stomach. The biggest thing is some people can have almost flu-like symptoms for the first few days after the medication. It is an injection, so very rare would be a little skin reaction or cellulitis. And unfortunately, it actually does have that same extremely rare risk of osteonecrosis or atypical femoral fractures. So it wouldn't be used in a patient who had that, but again, very rare. It's a great medication. It has actually better fracture risk lowering, so usually about 70%. What isn't as good as it is a medication. Once you're on it for over 2 years, it does need to be continued indefinitely. And if you are to stop that medication, you would need to then go on something else to prevent bone loss. It really was something that we saw in COVID because people couldn't even get access into their doctors for appointments. And this, unfortunately, we saw bone loss and higher risk of fractures in those who discontinued that denosumab medication. So we need to be a bit careful that a younger patient, someone who is 50, it may not be my first line because we know they're going to be needing this for a long time.
And once they're on denosumab or Prolia, are you still repeating bone densities in these patients? Are you still following them? How are you monitoring them once they're on this?
So we do actually. And so usually, again, I like to do one after 1 year to make sure that we're actually seeing a benefit, either a stable or a bone building. And then it is reasonable to slow down again every 2 to 3 years is the typical. Our guidelines are a little bit outdated, unfortunately, so we don't know. And 2 to 3 years may still be more than what is needed, but certainly an annual bone density is not required. After the first, when you're starting a new medication, absolutely to see the benefit, but then I think 2 to 3 years is plenty.
We'll jump to talking about supplements for patients with osteoporosis. So we've talked for years about calcium and vitamin D supplementation. What do you generally tell your patients about calcium supplementation when they have osteoporosis?
So calcium and vitamin D, they are the building blocks for our bones. And so we need to put fuel in the gas tank so that these medications can work and we can actually focus on bone building. There's been a lot of controversy around calcium supplementation. So it's recommended for about 1,200 milligrams from diet and supplements. But what's kind of come to light is some risk of cardiac issues, that calcium can be hardening the arteries and putting people at higher risk of heart attack. And so we really don't want people on high dose calcium supplements or pills. You're welcome to get it through diet, and we want it through diet. So 1,200 milligrams daily, but no more than 500 from a calcium supplement source. The best is obviously milk, but cheese, yogurt, but many of our vegetables also does contain some calcium, which can help us get to our 1,200 milligram target.
And I know Osteoporosis Canada has a calculator on their website that you can actually figure out based on diet and based on eating this much of these different foods, whether you get to the recommended calcium levels or not. And vitamin D, what are you telling your patients around whether to take it, dosing, any kind of generic recommendations you give them?
Yeah, so the evidence for vitamin D and calcium isn't amazing, but there is some evidence of hip fracture reduction. It was more for patients who were living actually in like a long-term care setting rather than just people who are out in the community. If you have adequate vitamin D levels without supplementation, that's probably not going to add a lot. So I do think if you're already there without it, you don't need to take it. Most people in Canada aren't. That is the reality, just because we don't have a lot of sunlight and we are predominantly indoors. So we're recommending between 800 to 1,000 for maintenance. If you had to do repletion, 2,000 is certainly safe. It would not require monitoring. I have had a number of patients who have come to me on quite high doses, 10,000 a day, and that is a time when people can be getting into trouble, and it can cause higher calcium and an increased risk of renal stones. So 2,000 is completely safe, but I wouldn't be going much higher than that without talking to your doctor.
And again, when patients typically are diagnosed with osteoporosis, it's one of the few conditions where we can actually get a vitamin D level that's actually going to be covered and actually useful. And again, if someone's vitamin D level is normal, like you said, they may not actually need to be taking supplementation on top of what they're on. And for patients with osteoporosis, what are you typically telling them in terms of what exercise is most beneficial for reducing the risk of fracture?
So we want to do weight-bearing exercises. So that means something that is actually going to help strengthen our bones. And that actually is most activities. Walking is great. You can do higher intensity like running or tennis or playing a sport. But most of our patients, we want to focus on something that they enjoy and will be consistent at doing. We want to recommend, at least 5 days a week. So most days, 30 minutes, and walking or brisk walking is what I tend to recommend. Swimming has excellent health benefits along with cycling, but they aren't bone building in the same way. So again, walking is great. It doesn't have to be skipping and jumping.
Thanks again, Dr. Brennan, for so much helpful information today about osteoporosis.
Thank you, Dr. Elia, for having me today.
And thanks again to Dr. Brennan for all of her helpful information today about osteoporosis. And until next time, stay healthy.